In patients with mitral regurgitation, important features on general examination include signs of connective tissue disease such as Marfan's or Ehlers-Danlos syndrome, signs of chronic inflammatory disease such as rheumatoid arthritis, lupus, or ankylosing spondylitis, and syndromes with associated valvulopathy such as Turner syndrome. Examining the hands and arms, focus on stigmata of infective endocarditis, signs of hypoxemia, pulmonary hypertension, and chronic inflammatory diseases. Patients with severe mitral valve disease are often in atrial fibrillation due to left atrial volume overload and dilation, causing an irregular pulse. Examine for high arched palate of Marfan syndrome. Also note the presence of central cyanosis, which can occur in patients with pulmonary hypertension. Look for signs of pulmonary hypertension, including an elevated jugular venous pressure and signs of significant tricuspid regurgitation, such as a prominent V wave. In mitral regurgitation, the apex beat is often displaced infralaterally, is diffuse, and hyperdynamic. A pansystolic thrill is occasionally present at the apex. Assess for a right ventricular heave and palpable second heart sound, which are signs of right ventricular failure and pulmonary hypertension. Move on to auscultation, starting at the apex. Press down firmly for diaphragm function to hear the systolic murmur of mitral regurgitation. The first heart sound may be quite soft. This murmur is pansystolic, heard loudest at the apex, and usually radiates towards the axilla. In mitral valve prolapse, there is a mid-systolic click, followed by a harsh blowing mid-late systolic murmur that extends to the next heart sound. In severe mitral regurgitation, a third heart sound may be heard with a bell function, which is due to rapid left ventricular filling in early diastole. We'll now go through a few maneuvers to accentuate any murmurs or irregularities. To accentuate the murmur, ask the patient to roll on their left side, listening with the diaphragm over the mitral valve during expiration. A Valsalva maneuver will decrease preload and accentuate and lengthen the murmur of mitral valve prolapse. Next, ask the patient to grip their hands together and pull apart. This will increase afterload and accentuate murmurs related to retrograde blood flow, including mitral regurgitation. Listen to the lungs for any pleural effusions or crackles, suggesting left heart failure. Palpate for hepatomegaly, pulsatile liver, or ascites which may be present with pulmonary hypertension, tricuspid regurgitation, and right heart failure. Assess the lower limbs for edema related to right heart failure. When summarizing your findings, consider the primary and secondary causes of mitral regurgitation and the consequences such as left and right heart failure.